good morning. My name is Paige. I am here to continue your lesson in airway management that you started yesterday. This is within the chapter of airway emergencies. Is everyone on board with that? I just wanted to make sure that yesterday you went over simple airway devices such as the nasal cannula, the non-rebreather, and the BVM. And you left off with just maybe assisting ventilations with the BVM. Great. All right, and you learned your techniques for using the BVM, which is your C and your E clamp, your head tilt, chin lift, and your modified jaw maneuvers. Yes? All right, great. So we're just going to add to what you guys have been learning up until this point. And we're going to add in a little bit of a complication. So we're going to talk about what to do in the case of a patient that is unconscious and what being unconscious means in means of airway control, airway management. So when someone is unconscious, we have a lot more risk of aspiration. They possibly do or do not have a gag reflex. And the most common problem when someone's unconscious is that their tongue kind of flops back into their neck, into their mouth. Because of this floppiness, when we use the BVM and we're ventilating for this patient, the oxygen's going into the mouth and it's not going to the lungs where it needs to go. So fortunately for us, we have devices that we can use when we are using our BVM. So these devices are called adjuncts, and we have what's called an OPA. This is the oral pharyngeal adjunct, oral pharyngeal airway. And then this is your nasopharyngeal airway. They are both used in specific situations, and we will go into the indications and contraindications of both. But the most important aspect of this whole entire lesson is that when you are assisting with ventilations with the BVM or providing ventilations in the situation of an apneic patient, you want to be able to tunnel the oxygen where you need it to go. So that's where these devices come into play. So I'm going to go through both of them, and I'm going to start with the oral pharyngeal airway. So in most people, like I said, that are unconscious, they are not going to have a gag reflex. However, if they do, this is out of the question and we'll go to an NPA. So before we go to insert anything into anyone's mouth, we want to make sure that there is nothing in the airway. We want to make sure there's no teeth, there's no vomit, there's nothing that doesn't belong, and that airway's nice and patent. So if it's not clear, then I'm not pushing anything inside this patient's mouth. So I'm going to make sure that it's clear, and it is. I don't see anything. If there was, I would suction. So it's nice and clear. Next, I need to know what size to put into this patient's mouth. Because obviously this is for a pediatric of some size, and this is for an adult. But there's also other varying sizes. So the way we measure this is from the tip of the mouth up to the earlobe. All right, so you want to think about this going into the oropharynx, and this is going behind the tongue, and this should be the appropriate measurement for this device. So once you go to the patient, let's start with this one. We'll go, the arch goes up, just like the anatomy of the mouth. And this one's a little short. Like if I start at the tip, it doesn't really make it. So let's start with something bigger. This goes to the tip and it goes to the lips right there. That's what I need, because I need this bevel right here to be on the outside of the teeth. So when we insert this, you want to put it in just like that. But if we do it just like this, we're going to push the tongue further into the back of the throat and completely obstruct the airway. So we are going to insert it bevel up. We're going to use a scissor technique, which is your thumb and your finger. You're going to push the mouth open You're going to insert this with the bevel up. Once you pass the soft palate and you have more room to work, you're just going to rotate this 90 degrees either way, and then it'll slide with the anatomy of the mouth. It'll just go right behind the tongue and it'll sit there. And this will just seat on the lips. Once it's in place and the patient's not gagging, we're going to use our BVM. We're going to use our CE maneuver. We're going to head tilt, chin lift, and we are going to give a breath. The goal is that this breath is less resistant than when before you were just using the BVM. Because now you don't have any obstructions in the airway. This air is being tunneled to the trachea and ultimately to the lungs. So that's how we use an OPA. So let's say that this patient started gagging. Like, oh no, they're gagging. So let's remove it. It comes straight out. We don't have to rotate it or anything. It comes straight out. If we need to tilt them to one side, if they vomited, hopefully they just kind of gagged a little bit. We've got our suction ready. And our partner goes back to using the BVM. And they're like, well, if they gagged, what can I do now? Well, hopefully you have an NPA in your bag. So an NPA is your nasopharyngeal airway. So this is going to kind of make sure the nose kind of flares open and it channels that oxygen back behind the tongue and into the back of the oropharynx. So it tunnels it where it needs to go. The measurement is pretty self-explanatory. We measured the oral from the mouth, so the nasal goes from the nose to the earlobe. And again, your arch is up. And it's just gonna go just like that. So this one's a little big, all right? This one goes like all the way up into that larger portion of the ear. So I don't want that. This goes to the earlobe. So I'm gonna use this one. Unfortunately, the nose does not come with secretions like the mouth does. So we want to use a lubricating jelly, water-based. Don't be putting any Vaseline in their nose. So a water-based jelly, we're going to coat it, and then we are going to insert it into the larger nair. Yes, you have a larger nair. It's typically the right one. You are going to insert it with the bevel towards the septum, and it should just slide right in. If you meet resistance, you can kind of wiggle it just a smidgen, but we are not going to push this in and cause a nosebleed, because now we have more problems than we started with. If you do meet resistance, you can see if the other nair is better. You would just rotate it till the bevel goes in. We're going to push that in just like so, and it goes in just fine. Sometimes people have lots of bookies in there. I don't know, they don't have the best nasal care. However, it should go in nice and easy. We shouldn't be having to use a lot of force. And then we can come back with our BVM. We can do our head tilt chin lift, nice CE clamp, and we can give a good breath. And hopefully we have less resistance than before. So just like anything else in EMS, we have indications, contraindications. For the oropharyngeal airway, the only major contraindication is a gag reflex, or if the anatomy is so deformed that you can't put this in. You know, if like a jaw is missing, or if there's too much going on, then you wouldn't be able to use this. For the NPA, your contraindication is deformity as well, but it's mainly deformity to the nose or the maxilla structures up here in your cheeks, or any type of indication that they may have a basilar skull fracture. So the bruising behind the ears, the bruising underneath the eyes. Excuse me, my allergies are kicking my butt today. So any signs that there's instability in the upper facial area, we don't want to push this in. For one, we don't want to push bone fragments down into the airway. And for two, there's a study that you could push this into the cranial space if there's like the perfect separation of the subdural area, and this could just kind of like go into their brain. So any signs of facial trauma that affects the nose and the maxilla, we do not want to insert an NPA. So then you say, Paige, well, what do I do if I can't put in an OPA or an NPA? You just make do with what you have until an advanced provider shows up that can secure that airway. So suction, use your BVM, try to do some jaw thrusting, head tilting, something until someone can get to you to help you out. All right, so everyone has a mannequin in front of them. You all have an array of devices. You have your large, extra large, pediatric, neonate, all the sizes that are in your jump bags. You'll put on some gloves because we practice like we play. I am not touching a patient without gloves on. People are gross. I'm going to put my gloves on, and then we will go through each step how to insert this. All right, guys? Everybody ready? Beautiful. All right, so put our gloves on. Nice, pretty pink gloves. All right, so let's say this looks like a good size for this guy. I'm going to measure from the corner of the mouth. It can go a little further into like the middle of the lip, but you don't want to go past that point. So corner of the mouth to the ear, that looks, oh, I need to be arch up. So arch up, there we go. Sounds great. All right, so we are going to scissor the mouth. Everybody good with that? Yep, we're going to push it apart. And then we're going to slide this and tip up, past the hard palate, rotate and secure. Beautiful. Your patient is not gagging. There's no indication that it's in the wrong place. There's no sputum or anything. There's no need to suction. So we are going to use our BVM. We are going to C and E on the jawline. We're going to head tilt, chin lift, and we're going to give a nice ventilation. We are either assisting this patient or providing the ventilation for them. Beautiful. Any questions about the OPA? All right. Next, we're going to insert the NPA. We're going to look at the nair. This looks pretty big for this guy. Yeah, I mean, it's pretty big. It goes all the way up into like his eyeball. So let's not use that one. So nair, that looks about right. Yeah. Back in the day, people used to say you can measure the patient's pinky finger. That's like a 50-50 chance. So when you measure these, always just measure it correctly. You're going to lube it up. I'm not going to lube my mannequin because he's a little fragile, but lube it up. We're lubing the tip. You don't have to go all the way to the top. And then we are going to bevel in and insert. No resistance, no blood. We are going to head tilt, chin lift, CE clamp, nice ventilation. Hopefully it's a little less resistant than the other ones. And we are in good shape. All right, guys. Any questions about how to insert an OPA, NPA adjunct or when it is indicated? Obviously, these people are not breathing or not breathing well, and they need some assistance with the BVM. So you guys have successfully used the oral and the nasal adjuncts. Just remember that anytime you are having to use these devices, that your patient is in a critical state, and that any time the airway can change. So always have your eyes on your patient and their airway. Aspiration does happen, so be prepared with your suction and be ready to turn them if you have to. As always, you guys are welcome to practice in the lab after class. And if there's any questions, feel free to reach out.